Good morning and good afternoon, everyone. Welcome to today's session on Voices of Healthcare Cloud, presented by myself and Shelly. Before we start, just a few housekeeping items. We'd love for you guys to have and pose any questions. So make sure to use the chat that you have, and I'll show you instructions shortly. All questions are moderated, so unless you ask them, unless we get a chance to publish, the others won't be able to sort of like them and show some interaction there. The recording for the session will be posted on aka.ms/HLS blog. After the session, make sure to check it out. It's the same location where you got the original invite in the first place. Let's move onward to how do you engage with the Q&A panel real quick. So on the top right, you guys would see a little question mark and a couple of chat bubbles. Make sure to click on those. And once you do, you'll have the option to ask questions. You can ask those anonymously or with your name. Obviously, for purposes of following up, we'd love to have your name attached to the question. So make sure to leverage the Q&A functionality. We'll be monitoring the chat for questions, and answers will follow either in line or during the presentation itself. With that, let's move on to the presentation. I'm going to turn it over to the two presenters for today, my colleagues Shelly and Josh. Shelly is a senior technical specialist in our healthcare and life sciences practice, and Josh is a rockstar customer success manager within the same HLS discipline at Microsoft. We're going to talk about multidisciplinary huddles with Microsoft Teams today. And with that, let me turn it over to you guys. Shelly, take it away.
Hey, and good morning, good afternoon to everyone. We're so excited to be here with you today. I'm usually in the background producing these events, and so I feel privileged and honored to be able to be the presenter today. And I'm joined by Josh Thompson, who I feel is my partner in crime. We work very closely together with many of the healthcare customers with Microsoft in the Central region. And we are just really, really thrilled to talk to you about what we've learned over the last 18 to 24 months on how our customers are taking advantage of Microsoft Teams for their multidisciplinary huddles. Josh?
Awesome. Yeah, thanks, Shelly and Vasu, for that introduction. So as Shelly mentioned, I'm a customer success manager focusing on Texas and Louisiana healthcare. Really passionate about healthcare and have had some great experiences working with customers, helping them better leverage and get greater value out of our technology. So excited to present today on one of those stories.
Awesome. So kicking it off, we wanted to start off with thanking you all for coming here today, and wanted to just have one kind of side conversation with you. Microsoft is trying our best to partner with our healthcare customers in all areas of the patient care journey. And so right now we know it is huge for our customers to be able to have that seamless virtual health for both patients and for their clinical workers. It is just as important for these virtual health tools to work efficiently and effectively for the patient, as well as the doctor and the nurse and all of the clinical care team. And so you can see the patient journey here on the slide. All aspects of this patient journey, Microsoft has areas that we can help impact in the care team and the technology layer that is out there. But today we're really going to focus on this clinical collaboration, kind of that inpatient or in-hospital huddle experience. And so if you have use cases in any of these other areas, please reach out to either us or your account team or your customer success managers to talk about how we can partner with you in these other areas as well. So for today's conversation specifically, we want to talk about huddles. We called it multidisciplinary huddles because a lot of the use cases for huddles include the entire care team. We've learned that it's not just about the doctor and the nurse. It's about the charge nurse. It's about administration, social workers. It's about pharmacy. It's about getting ambulatory, or all sorts of areas of the care team together and prepared for what that day and the upcoming days are needed for the care plan of that patient. Sometimes people call these rounds. Some people call these huddles. We've heard MDRs, IDTs. We've heard them called readiness huddles, situational awareness huddles. So you pick your flavor and insert the title or the type of huddle or round that you do in your organization, and hopefully we can show you some really cool tricks as to how we've seen our customers create efficiency and value out of digitizing their huddles using Microsoft Teams. So to talk specifics, here is some images that hopefully you aren't as familiar with now, but maybe you are. We have had the opportunity to walk the floors and the hospital units of many of our customers, and these whiteboards are very common. One particular hospital system that we got the chance to shadow or follow in a day in a life was really keen on their situational awareness or readiness huddles. And this started at the unit level with the nurse manager meeting with the on-call, nurses and pharmacists and care team that was there, really just talking about staffing and census and any kind of announcements, updates, or praises. And everything was documented on a whiteboard. And then that nurse manager then went to a tier 2 huddle and met with all the nurse managers. And they basically reported the same thing again. It was put on a whiteboard. And then to tier 3 with the facility leaders, and then to tier 5 with the operational leaders, and then even all the way up to the system level executives if a issue or case needed to be escalated that high. And so we, after shadowing them and learning about their goals, one of the main things that was challenging was data collection and then sharing that data up with each tier, because what they did was at the end of each day, they erased that whiteboard and then they wrote over it. And so they lost all of the data from day to day, and it was all manual tracking. And so we were able to work with the organization to at least get the data in a digital form very quickly so they could collaborate on this data in a digital state. We were told by these customers that they were very thankful to not be fully dependent on that physical whiteboard, especially when many of their leaders had to go home recently due to the pandemic. And so having those digital, that data digital, really helped them to continue with their huddle process. Another customer, this is a completely different facility that we visited, that they focused on multidisciplinary rounding, specifically to reduce the average length of stay. So they really focused on discharge planning. What could they do to remove barriers for discharge? When the patient was medically ready to be discharged, but some administrative or logistical gap kept them overnight, or if they didn't get the discharge order complete by a certain time in the day, they would be charged for another 24 hours. But then that insurance bill back was costing them extra days, even though the patient really was only there for 30 minutes of that 24 hours. And so they were really keen on collecting the data necessary to be prepared and efficient in getting their patients discharged once they were medically ready. And so same kind of challenges here that they faced with their multidisciplinary rounding. And so I think Josh is going to dig into what some of those challenges were for these customers.
Awesome. Yeah, great job, Shelley, setting the context there. And so you can see here kind of the list of common themes that we found as we went and observed various organizations and we interviewed nurses and doctors and other things. And so the very first one is awareness. With these paper-based or whiteboard-based, solutions, clinical workers needed to be physically present for the huddle. And oftentimes, doctors and others were double booked or triple booked. And so they couldn't be there to learn key information that they needed to take care of their patient assignment that day. And they also couldn't share the information that they had gleaned, maybe from doing their rounding that morning. There were also challenges with awareness from one shift to the next with overnight shift handoffs. And so it resulted in limited information being shared during that time. Another concern was security. Our joke was that the information was so secure that if you walked by, you could just wipe it off with your sleeve if you stepped too close to the whiteboard. Or if you spilled coffee on your sheet of paper that you were taking notes in, then that could be lost. And so information security, also having those whiteboards or papers, the papers could be dropped in a hallway, or the whiteboards in some cases, most cases, they were in a nursing unit. And so having kind of the information secure in a digital format added an additional benefit. Data accuracy, it was very common because they had to always go back to the unit to update that data, that things got so busy during the day that they wouldn't do that. And so the information was good at 9 o'clock or 10 o'clock or whatever time they had their huddle. But then within an hour, 2 hours, 3 hours, that information became very stale and irrelevant. You wouldn't know if John Doe had actually gone to get the scan that he needed, or if that last step for Sally before she could get discharged had been completed on time. And so that data accuracy was very challenging. The limited information was kind of interesting. So with paper and physical whiteboards and other kind of more analog formats, you were limited by what could fit within that little box. And so that was something that people expressed a lot of frustration around, things like challenges around reading handwriting and other things. And then there was no long-term learning based on any of this data. So things like readmission rates or predictive analytics around what is actually driving length of stay, that was challenging. And also learning around where are the operational bottlenecks? Where are the places where if they go, we know that there's going to be a bottleneck there and that could increase their length of stay by X%. And so that was another challenge in getting that feedback from the clinical workers. And then the last one, which Shelley had already mentioned, was consistency. If people couldn't be physically present, then they just didn't participate, which oftentimes kind of disrupted what was able to be shared during that huddle process. Or recently, with everything that's going on around COVID-19 and wanting to limit who is physically present in a unit or on a floor, that could be very disruptive and has been very disruptive for organizations that relied on more analog or kind of in-person methods instead of digital or virtualized methods. And so as we met with all these clinical teams, these were kind of the 6 kind of key challenges that we kind of pulled out. And then through some of the solutions that that we were able to help implement, we were able to overcome most, if not all, of these. Let me go to the next slide. And so here, thanks. So here, we want to kind of dig into one particular story at a customer where they wanted to prove out this concept. And so we piloted it. And we did a pilot with, it was actually 4 units that tried leveraging Teams, switching from a physical whiteboard kind of paper-based process to a digital version that used Teams and some of the technology that we'll show you here in a minute. And then we had 2 other units that served as control groups, and they were all acute care units. They were the same type of unit with same leadership and everything else. But you can see here that there were drastically different results over the same period of time, where those units that were leveraging Microsoft Teams and some of the other technologies saw a length of stay that definitely trended down over time. And during that same time period, the control units that were kind of doing things the old-fashioned way, they saw length of stay increase and trend up very dramatically. And so we'll dig into kind of what they did and how they did it and stuff here in a moment, but wanted to share those performance results. And these graphs are showing length of stay, and then talk about the financial impact, which most of you may be familiar with. But just for those 4 units that saw the length of stay decrease over that period of time, they estimated that on an annual basis, that could save them $838,000 for 4 units, which could be very significant when spread across an entire hospital system. And you can kind of see here some of the numbers that they leveraged, to calculate that, looking at sort of the cost, average cost for like the last day of a patient's stay, factoring in, hey, if we eliminated those avoidable delays, for an entire year, how many days could we save, and then what would be the financial outcome of that? And so there's a lot of efficiencies to be gained here, and we certainly hope that as we partner with you all, that we can help to create financially efficient ways of doing things as well. So I think now we are going to dive into the demo and really just kind of dig into some of the technologies that are available. Like Shelley said earlier, there's a lot of technology that can touch this patient journey. And so we'll really just be touching on kind of a small area of it, and then happy to work with any on what that could look like for your organization as we move forward.
Thanks, Josh, so much for partnering with me on this one. So we are moving over to a live demo. And so want to call out one thing prior to the demo is our customers who we worked with, these readiness huddles, situational awareness huddles, MDR huddles. We used a solution that is called lists in Teams. This is actually just recently generally available to all Microsoft tenants in the world. But these few customers were able to get access to it early and actually helped us develop and build the solution specifically for these healthcare use cases. You can see on the screen we have templates. One is the patient's template that is actually modeled after the multidisciplinary rounding for discharge planning. And you can see also just kind of how it looks. It is everything that we show today, we're going to be showing in the web browser, but it's also available in the full Teams client as well as on mobile. And so the mobile aspect is really important too, because those whiteboards or even Excel spreadsheets, as we've gotten some of our customers to move to Excel instead of whiteboards are very beneficial digitally, but as soon as you move away from a large monitor or a laptop, Excel gets very hard to manage, pinch and zoom on that mobile device. So these lists really make it interactive and editable on the go. So with that, let me switch over to a demo.
And while you're switching, Shelley, I'll just call out, in case it's a question, that everything that we're showing is HIPAA compliant, HITRUST certified, and so there are no risks or anything around having patient information within Teams. Lots of customers do that today, and we certainly have documentation around that.
Yeah, absolutely. Thank you for that. So inside of Microsoft Teams here, hopefully you've all used it, at least for some basic chatting and meetings. We are on our live event today, so hopefully meetings is not new to you. But what we're really going to do is focus on the collaboration space of Microsoft Teams. You notice that I have two teams here on the left-hand side. Each of them is really designated to the two use cases we're going to review today. So the customer around situational awareness, readiness huddles, or even tiered escalation huddles, we modeled here in the Smarter Health escalation team. You can see we have multiple tiers represented here in channels. Tier 1 being the care team and the managers, the unit level. Tier 2, just slightly above that, clinical directors. And then 3, administration in the hospital, all the way going up to executive leadership if needed. And so what we did with this use case is we created a list or a readiness huddle board. So just like we saw on those whiteboards, each and every whiteboard was a list of rows and columns. Rows usually representing a patient or issue or concern or status update. And then the rows was the different data associated to that issue. And so this readiness huddle is modeled after the STEPS way of collecting data, standing for safety, technology, equipment, process, and supplies. And so they're collecting the data in each of these categories. As you can see, that this information is easily accessible and very, very clean and clear. We can come in and edit very quickly in a grid view that allows us to edit in real time very quickly all of the issues that are on our board. We can even add new items very quickly. One of the challenges with a physical whiteboard with this customer was if an issue arose in the middle of the day, most of the clinical staff would just add a little sticky note onto their legal pad or spiral notebook that they were carrying around throughout the day, and they had to remember that until the next day. But sometimes it would be, they would do 3 on, 3 off, so it'd be the 3rd day of their shift, and so they would then have to pass that sticky note to another person to then attend the huddle the next morning. And so having the ability to quickly add an item right on your mobile device on the fly or at a break or when you're sitting at the nurse station really created more on-demand way of collecting this type of data. In addition to that, you can click into the issue or record to see additional information or double click and be able to update this, adding attachments, and even having a Teams conversation about a specific issue. Here seeing that this doctor's keyboard isn't working and we need to get an update. So we got an update via chat that this keyboard had been replaced. Also, you can take this issue and copy the link, just like you can copy the link to a file or Power BI dashboard, and then share that with somebody potentially in email or in chat that might not be in the team, and you want to get their input on it, you have the ability and the flexibility to share that with others.
Two other things, Shelley, just while you're on that screen that I'll call out that we found in our research was, one, it was very challenging for clinical workers, whether they were nurses or nurse managers or doctors, to get an aggregate view or understanding of their patients. And we found that the most stressful part of their day were the first 2 to 3 hours, which were often spent trying to figure out, hey, what happened since I left yesterday? And so having this type of aggregated view was incredibly beneficial. And the second thing I'll mention is just thinking in terms of like shift handoff, going from an AM to a PM shift or PM to an AM shift. This solves so many problems that a lot of clinical leaders didn't even know that they had, because finally this PM shift, which they were grossly understaffed relative to the AM shift, just many fewer people working. But they felt that they were finally able to contribute to length of stay reduction in an effective way. And so that was just another benefit that we found.
Absolutely, Josh. The switching over to more of the patient huddle or the multidisciplinary rounding or IDT or shift handoff huddle, as Josh alluded to here, instead of issues or the steps process, we have a list of patients. And you can see that this list can be customized. We have templates that will allow you to help set this up to get started, but you can easily add new columns, drag and drop additional columns here. When working with the customers, we found that they quickly learned what the blockers were or barriers to discharge. One of the ideas that they came up with was knowing the goal of where they were going to discharge the patient, whether they had a home to go to, if they needed to go to SNF, or if they were homeless, or maybe they needed to go to rehab, was very important to the social worker in partnering with the clinical worker in preparing the discharge order, so that when the doctor put that order in, they already knew which rehab center or which facility this patient was going to. Potentially the patient was going home and they needed to arrange transportation and communicate with that next of kin to make sure that they were transported properly. Again, that's just one example. They also talked about knowing what durable medical equipment they needed to be prepared to be discharged was very important for them to call out early in the care plan so they could prepare for that discharge.
Hey, Shelley. Sorry, we have a question from Dr. Velasco. And so he would like us to comment on the integration of teams with the EHR. And so being able to pull in patient information into teams instead of having to copy and paste or type or do something else into lists.
Sure. Thank you so much for attending, Dr. Velasco, and an awesome question. So the answer is absolutely we can. It's not an easy answer though. Beyond that, it does require either an HL7 or FHIR interoperability layer to pull that data in. But absolutely, this is something that we can do using either native FHIR or HL7 within Epic or Cerner or Allscripts, or if you aren't at the version of those EMRs that support interoperability, we can leverage either Azure FHIR services or even third-party interoperability partners like Cloverleaf or Redox. There's a handful on the market. So absolutely, we can do these pulls to update automatically and get this information into these lists. As Josh mentioned, the data mining as preparation for these huddles each and every day, we learned that the nurse managers, the nurses, the care teams, the providers were all spending 30 to 45 minutes or even an hour individually, all preparing for this huddle that happens at either, sometime between 8 a.m. and 10 a.m. each morning. And so by aggregating this information that is either automated or manually updated, but by a centralized location, each person on the care team was able to benefit from that updated data, as opposed to each and every one of them having to go out and data mine in the EMR or in the lab system or in all of the different systems that you have. And we not only can integrate with the EMR, we can integrate with other systems as well. So if you're wanting to pull in data from labs or from transportation or things like that, we absolutely, it's not just kind of a one-to-one, it can be many to one to aggregate from multiple systems. And then on that note, we can also use Microsoft's either bot framework or even our Power Platform to automate alerts based on this information. And so two I like to call out on the screen. You can see this row Sean and this row Matt. You can see these dates are bold and they have these little red indicators over here. For this use case around average length of stay, this is a calculated field and it's alerting us that their discharge target date has passed. So there is an assessment that goes on based on the condition of the patient, the diagnoses of the patient, that the clinical staff says, based on our abilities and knowledge, we should be able to get them discharged by X date. And so as they are approaching that goal or have passed that goal, it's going to send visual indicators, and we can even send triggers or alerts to folks to say, hey, we have 3 patients on our unit where today is the discharge date goal. Should we update that discharge target, or are we working towards getting this patient discharged?
Yep, and that's a great call out, Shelley, the ability to add in that Power Automate to and other technologies to create those types of data alerts, that could be potentially customized to an organization's or facility's needs. Really, really powerful stuff.
Also, there are different views. So for example, here we created a view for Dr. Addison. We learned that many units have a dedicated nursing team, but not necessarily a dedicated provider team or doctor. And so a lot of times there might be 4 or 5 or 6 doctors that have, 3 to 5 patients on multiple different units. And so what that doctor is able to do, regardless of unit, create a view where they can see all of their patients in one list, and just, again, aggregating that information, being able to update the data, and then it is pushed out to all the various units so as the nurses and care teams are rounding together or huddling together, they can see those real-time updates from those doctors. Also, just sorting by different views, maybe sorting by length of stay or sorting by unit. We're also seeing the data collection on these. And so one other area we would like to call out with regards to using digital way to round or huddle is the ability to collect that data. Josh talked a lot about the challenge that they're faced with when the data is just kind of wiped off the whiteboard and then replaced each day, is how do we learn from this data? And so we can also pull all of this information into Power BI dashboards. So even leaders who might not be rounding or huddling with these clinical workers each and every day can have different dashboards that are shown to them, or that they can look at, or collectively talk about in their meetings around potentially, how are we doing on discharge? Josh and I also had the opportunity to meet with a CFO over a large hospital system who was very, very focused on discharge planning and reducing average length of stay, but it was more from a financial perspective than from a medical perspective. So everybody in a hospital organization is focused on that care plan for the patient. They just have a different viewpoint. And so we can create these dashboards to be aligned to either a clinical staff or leaders, or even financial or operational leaders. But by collecting this data and being able to learn from it and drill down into it, to be able to always be improving, that lean model of finding an area that we are doing well or an area we're not doing well, learning from the areas we're doing well, updating the standard of work, and then implementing new processes to influence better outcomes and behavior is really our goal here. So these are interactive, but if we wanted to drill down into maybe a specific unit, it would update, the data, based on that. We could even drill down into specific DRGs or diagnosis codes to see how we're doing in certain areas, to learn if there are areas for improvement in the system.
One thing on that, you already talked about the benchmarking potential, Shelley, and the ability to compare, hey, this hospital versus this hospital, how are we doing, or this floor versus this floor. But something else that this enables, based on the feedback that we received, was actually just a better I'll call it quality of life for clinical workers. We found that a lot of them were getting Excel exports and then spending time in the evenings trying to manipulate that with pivot tables and other things, just to get an understanding of this data for a leadership meeting the next day. Or they would get these sort of ad hoc requests to, hey, we need to talk about everybody who's been in our hospital for 10 days or more, or 7 days or more, and come with that list prepared. And so having this type of access to data really streamlines and improves their ability to answer those questions very, very quickly, and to have a consistent understanding of how they are performing with regards to any number of metrics.
Absolutely. So one last thing we want to talk about is, now that in these scenarios, once everything is digital, it allows for another level of flexibility. We also found, one of the challenges was that doctors needed to be at multiple places at once, and they're so sought after, but they really can't unless teleportation becomes a norm. But the easiest way to be able to be somewhere or multiple places at once is if you can do it virtually. And so you can see we have an example here in the Microsoft Teams calendar. We have set up the daily Teams huddle, and these could be at various different times in the day for different durations. But what a doctor would be able to do is, if they had multiple huddles they needed to be at that were very close in time, as opposed to having to walk from one unit and then hustle across the hospital that takes them 10 minutes to go down the elevator and run down the hall and up the next elevator, they could virtually, like we are today, use meetings to participate in those huddles. And since the data is now digital, that data can be shared in the meeting or even accessed via Microsoft Teams, and they don't need to physically be present at the nurse station to be able to see those huddle boards or to see those whiteboards that are on the physical wall. We see Surface Hub either the older version or the newer version, Surface Hub 2, playing a really huge part in this. Also, if you are wanting to display this information at the unit. Also, TVs from a display perspective work, but that Surface Hub really gives it that interaction that a lot of our clinical workers are wanting to be able to do that on the fly as they are rounding or huddling and wanting to update that data.
It also, I guess, enables more of an on-demand consuming of that information as well. If for whatever reason they're triple booked and they can't make that third one, the huddles can be recorded and they can be made available to the clinical team. They can be transcribed automatically so that a doctor can go back later to see, hey, what did somebody say about the patient in room 307 or Mr. Jones in room 506? And that can also, coming back to shift handoff, really help from a shift handoff perspective for that PM shift, maybe to go back and be able to understand what was discussed in the huddle earlier that day.
Hey, Shelly and Josh, I'm getting a question here about what made you choose lists over, kind of another way of surfacing tasks, items, like a planner or an Excel sheet. Can you talk to the extensibility of lists and how do you find it in the first place inside of Teams with the new list app? Can you speak to that a little bit, please?
Yeah, I can start, and then Josh, I'd love for you to chime in.
Yeah.
Lists was actually not our first choice. We had a problem, and we worked with Microsoft engineering to come up with a solution. And Lists was actually the outcome of that process of working with the clinical workers. And so the template, the patient template or the readiness template that were created was a result of these engagements with our customers. And so templates can be made very easily, but how you add a list into your Microsoft Teams is by just clicking the little tab icon and then clicking on lists. And so when you come into lists, what it's going to do is just take a few minutes to get lists or a few seconds to get lists set up. And then it's going to give you the ability to pick, either create a list that's already in existence or create a brand new one. And so if you create a new list, this is where the templates show up. So if you already have an Excel spreadsheet that is rows and columns of data that you want to import from lists, we highly recommend upload from Excel. This doesn't have to be for clinical uses. We have financial departments uploading Excel documents and using lists. I think another great use case is we have an HR team that's monitoring all new employee requisitions that they get for potential new hires, and then the status updates of when the hiring manager or the HR manager has done their screen, and then the hiring manager has done their initial interview, and then as the applicant goes through their background check and their drug screen, and then when they're cleared for employment, that's another use case we see for lists. And so you can see employee onboarding is listed here, or even asset management, lots of different use cases. So once you click on the template, it's going to preload a view of what that template looks like, giving you an example of what the rows and columns would look like. And if it's close enough to what you're looking for, you can use that template and then customize based on your needs. Or if it's not close, you can just start from scratch and then add the rows and columns that you want. So I hope that answered the question. Josh, anything to add there?
Yeah, so I would also say, as far as lists versus Excel, there were a few other things that we took into consideration. And so one was kind of the mobile experience across the tools. And so oftentimes, joining from a phone if they can't be physically present, Lists was really designed to be a mobile-first solution. So it works really, really well on a smartphone. Sometimes with Excel, having to pinch and click on the cell and edit the cell, it's just a different experience. And so I think that was, a factor, as well as the ease of integration with some of the components of the Power Platform that we've already discussed. So Power Automate to set up data alerts and other things, as well as seamless integration with Power BI, with SharePoint, and other applications within Office 365.
Thanks, guys.
Yeah, no, it's a great question.
There's another quick ask about how does this play with sort of something like a whiteboard instead of a Teams meeting. So if I'm running my huddle, whether it's weekly, daily, and I have images and I like people to scribe, can this accommodate for the whiteboard experience also, or should I look to choose one versus the other?
Yeah, that's a great question. I think they can be used together. If there is data that needs to be kind of edited or scribed, ad hoc in a meeting, that whiteboard becomes very powerful for that. If that needs to be stored or then shared, with the care team, there is the ability to add attachments or URL links to each of those patient records. So let me just navigate back over there on the demo and expand one of these rows. And so if I open up this record here, the whiteboards are like online files. So you can grab a URL of that. If you wanted to post the URL in a conversation here to say, hey, we reviewed these images and there's notes on this whiteboard, you can post it here. And then also there's the ability to attach attachments. So if maybe there is a image of, if you're in the situational awareness or readiness huddle, maybe there's an image of a spill, or there is a damage in a bathroom or something like that. I could see how, uploading images or files here would be, a good way to link things like whiteboard or image upload and using it in conjunction with kind of the huddle process.
Yeah, I would view it as very much complementary versus conversation, depending on what the need is for that particular huddle.
Yeah, thanks, guys. So one more question. It's about how do you scope the solution, right? And so the idea being, many organizations have visiting clinicians or folks who are not part of the actual organization. How does the solution work for guest users, and what is the process for that? Can you comment on that a little bit?
Yeah, so as far as guest users, we've had other organizations where they have Teams allows for guest users. It's a question on whether or not your organization allows those guest users to be a part of the team. And so you can invite other individuals, whether they are partner physicians or I know of other organizations that are partnering with paramedic groups and in-home care teams and others, and they can be invited to the team as a guest to contribute specifically within that team if there is, specific files and conversations and other resources and content that they need to have access to. Some organizations make the decision to disable that guest access, and maybe at first when they deploy Teams. But as those needs become more and more prevalent, we often see those kind of security and access controls open up to allow those partners to fully participate. And from a chat perspective, we actually see lots of benefit from that because Team provides secure and compliant, HIPAA compliant chat. And so even if it's just from a chat perspective, you can still have internal care teams communicate with external partners and others in a HIPAA compliant way as well.
Thanks, Josh. I
Yeah.
think we're in a spot to open up for more questions. So if any of the attendees want to quickly type up something in the chat window, happy to take the questions now. After having seen some of these implementation guys, what are some other nuances or areas of consideration you should keep in mind before proceeding with this type of a solution? Can you make a quick comment on that while we wait for more questions?
Sure. I would say first that what we showed, that there are lots of ways to do this. There's lots of different types of huddles and organizational requirements and ways that they have applied operational excellence or lean principles and other things. And so what we really showed today was hopefully how different pieces can potentially come together to create an effective and powerful solution. But even within this topic of clinical huddles and care coordination, there are lots of other ways, like Dr. Velasco was asking us about, that the technology can be leveraged differently or otherwise to add even greater value or different value if that's what the organization needs. And then beyond just the huddle, as Shelley showed earlier in the presentation, this exact same technology that we've talked about can be leveraged throughout every stage of this patient's digital care journey. And so lots of opportunity for scenarios outside of this. It's really just a question of deciding what's the priority or the scenario that we want to kind of tackle first, and then we are more than happy to work with you to make it a reality.
Yeah, and one thing I'd add is actually Josh is really good in this area, and our entire CSM, our customer success manager community for healthcare is really great in this area, is walking alongside of you to help you templatize this and then even start a pilot. So we did a pilot with both of these organizations that we reviewed today, and learned through that pilot what was great, what had some kinks, and then improved that before going out to the masses. So we did start small, a couple of units, you know, in each scenario, kind of honed the board, and then we created a little bit of training and communication around that to then roll it out to the rest of the units at a specific facility and then system-wide. So you kind of that crawl, walk, run, and Microsoft is happy to partner with you. It's technology that I assume the majority of you own and have implemented, but also if you don't have it implemented, that's something else that just from a team's perspective, we can help you with, get that enabled, because that's really the foundation of how this care team collaboration gets started in your organization.
Thank you, Shelley. Thank you, Josh. I don't see any other questions on chat right now. So maybe we can wrap up and give people some time back. Thank you guys for presenting, and for those who are attending, stay tuned for our next of the series. We should be bringing something to you shortly, early next month. Most likely we'll have it finalized and updated on the HLS blog. So thanks again for joining, guys. Look for the recording and the slides on the same blog post. And we'll look forward to meeting you again soon. Thank you. Thanks, Shelley. Thanks, Josh.
Thank you.
Thanks.